Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is May 22nd, 2024, and I'm your skeptical host, Ken Milne. The title of today's podcast is I'm Gonna Need Someone to Help Me. GRACE4 Alcohol Use Disorder and Cannabinoid Hyperemesis Syndrome Management in the Emergency Department. And our guest skeptic is Dr. Bjug Borgundvaag. He is the founding director of the Schwartz Reisman Emergency Medicine Institute at Sinai Health System. He's a professor of emergency medicine and a clinical scientist in the Department of Family and Community Medicine at the University of Toronto. Prior to his medical training, he completed a PhD in pharmacology at U of T. I love pharmacists, by the way. He's been involved in ED-based clinical research examining ways to improve care for patients with alcohol use disorder in the ED for over 2 decades. Welcome to the SGEM, Bjug.
Thanks very much, Ken. I'm super happy to be here. And I'm very excited to have a chance to talk about this paper that we recently published.
Whoa, don't get too excited, but I understand you have a real passion for this area. What got you so interested in exploring alcohol use disorder?
You know, it's a long story, but I think I can summarize it pretty quickly. Before I went to medical school, my very first job in research was a research assistant when I was an undergrad, working in a lab, studying alcohol use disorder in rats, if you can believe it. And that was 40 years ago. And somehow I became very interested in pharmacology, and I was very interested in alcohol use disorder. And then I ended up as an emergency physician, and I was shocked to find that alcohol is a thread that's woven through so many different presentations in the emergency department, and unlike unlike somebody who gets diagnosed with cancer today and gets sent to a nice clinic and everybody holds their hand and sings kumbaya, if you have alcohol use disorder, which is the number 3 cause of death in the world, and you come to an emergency department, people for the most part don't know what to do with you. And there's a great deal of stigma around it. And so at this a late point in my career, I've sort of made it, this has been something I've been interested in for 25 years, but I really feel that I want to do whatever I can to try and find ways to improve care for this group of individuals.
Wow, I can't believe our stories go back together. I started in a research lab 40 years ago. Now, I wasn't studying rats, and I don't know if you got a lot of rat jokes from your friends back then, but I was doing fetal physiology and reproductive endocrinology working with sheep. And, here we are 40 years later, a couple of emergency physicians talking about alcohol use disorder. And I didn't realize that it was the number 3 cause of mortality, I think you said, worldwide?
Yeah, worldwide.
Wow.
There are more people admitted to hospital in Canada every year directly related to the harms caused by alcohol than there are people admitted to hospitals in Canada with coronary artery disease.
Those are just like wow kind of statistics. I wasn't surprised when you said that there's stigma around this, because certainly when people come in with alcohol use disorder or other substance use disorders, there certainly seems to be a lot of judginess. And it'd be nice if that didn't take place, but we're not here to solve that. We're here to figure out what's the best way to approach these people. What's the best evidence available to help these people? Because we're not in the emergency department to judge. We're in the emergency department to help. And so we're going to go through some of the evidence that supports the management of these people. But just to back up one little bit, I'd never heard of this music, and you picked the music for this episode. It's not from the 1980s, so clearly that's why I don't recognize it. So who's the singer of this song, and why did you pick this song?
My daughter got me interested in country music a few years ago, so I was listening to some of her country music selections, and I came across this song by Nathaniel Ratcliffe and the Night Sweats, and it is just a graphic description of what it's like to be an alcoholic, to have alcohol use disorder. It's somebody who's desperate to stop drinking and gives a very vivid description of what it's like when you start going into withdrawal. I thought it was fitting for today.
Well, we like both kinds of music here, country and Western. But if it's not from the 1980s, I don't recognize it. So can you give us the official reference for the paper we're going to review today?
The paper is published in the May edition of Academic Emergency Medicine, and it's entitled The Guidelines for Reasonable and Appropriate Care in the Emergency Department. The short form for that is GRACE4, Alcohol Use Disorder and Cannabinoid Hyperemesis Syndrome Management in the Emergency Department. The topic really we were given to discuss was non-opioid addiction in the emergency department, and that's how we ended up with these two seemingly very disparate topics.
Well, I was looking through the authors, and you're the lead author, but there are some really amazing people on this guideline. There is Fernanda Belliolio, and she's from the Mayo Clinic. She is fantastic. And then I saw Evan Schwartz. He's out of UCLA. Evan's another great physician. And then there's another Torontonian there, Hassan Sheikh, and he's been on the SGEM before. And then my good friend, Sunil Upati out of McMaster takes me back to my best evidence in emergency medicine or BEAM days. And then, of course, the final author, my BFF, Dr. Chris Carpenter. I don't know some of the other authors if you want to give a shout out to any of them, but it looks like a great group you put together.
Yeah, we were really fortunate to get a group of experts in a variety of aspects of addiction and emergency medicine. So Chris Carpenter and Fernanda and Sunil were methodological experts. And as was Samir Sharif, they help with our grade methodology, our analysis of the data that was available for this. We had a few toxicologists in our group. We had some addiction medicine specialists, people who practice emergency medicine and addiction medicine. The group is international. There were a bunch of authors from across Canada and the United States, and they are a fantastic group. We also had, importantly, a couple of people with lived experience. So Rob Velland is a person recovered from alcohol use disorder. And Anna Monkley is somebody who was able to inform our discussions around cannabis hyperemesis syndrome.
Wow, not only did you include people in the guideline process, they're authors on this publication. I think that's fantastic.
Yeah, they had a really loud and important voice. And I think it's good for us clinicians. You know, we often think we just want to do this and do that, and we just tell patients. But it's really important to hear what patients feel about this and think about this. And they had a lot of thoughtful comments on the care that they had previously received in emergency departments.
But to have them as authors on the like, that's not just tokenism. We've got to have some people, some lay people or some people with lived experiences, some patients on the guideline process. They obviously were involved all the way through the process and right up to the final publication and being authors on the publication. I think that's again fantastic, because evidence-based medicine, as you probably know, involves three pillars, and you've gone through and searched for the best evidence. Okay, so what's the relevant clinical literature? And that's one of the three pillars. And people often mistake evidence-based medicine for just being about that pillar. But then you mentioned you have clinical expertise. You have clinicians, emergency physicians, people that have expertise in addiction medicine, so they can talk about their clinical judgment. But that third pillar, that sometimes it seems to be forgot about pillar, is what about the patients? That's why we're here. And so asking them about their lived experiences, their journeys, their values and preferences is just so important. So I'm just over the moon over this. This is fantastic.
We were super grateful. It was a big commitment on their part. This project actually took a long time. These people had to take a lot of time out of their work days to participate and share their thoughts with us and review the material that we produced. So I'm extremely grateful to our people with lived experience. Yeah, it's great.
Well, this is an SGEM hot off the press, but with a twist. We're not going to do a structured critical appraisal of the GRACE4, but rather we're going to turn this into an SGEM Xtra. So we're going to combine an SGEM HOP with an SGEM Xtra, and I hope we get some, what's the word I'm looking for? Amazing knowledge translation for this amazing GRACE4 publication. And because it's GRACE4, that must mean there is a GRACE 1, 2, and 3, and there has been. And GRACE 1 looked at recurrent low-risk chest pain in the emergency department. GRACE 2 said, okay, what about recurrent low-risk abdominal pain? And the most recent GRACE was GRACE 3, and that was on dizziness. So for this episode where we combine a HOP plus an Xtra, we're going to give a case scenario to set the table. We'll do a little background information. Then we're going to ask a very specific clinical question, provide the author's conclusions, and it's great. We have the author right here. And then we're going to go through any of the recommendations that came from that and provide a case resolution. Sound like a good plan?
It's great. I love it.
All right. I'll set the table with case number 1. Let's imagine you have a patient presenting to the emergency department and they've got some nausea and vomiting, some abdominal pain, and complaining of alcohol withdrawal. This patient reports that his last drink was 9 hours ago, and he typically consumes about 60 ounces of spirits per day. He has a prior hospitalization for the management of alcohol withdrawal, including seizures and 1 prior episode of delirium tremors, or DTs. So what's your initial management? What are you going to do?
The key, we believe, for the management of alcohol withdrawal is to use a symptom-guided approach where the treatment is tailored to the severity of the withdrawal. There's not a huge amount of evidence, but there's at least 2 randomized controlled trials showing that people who get symptom-guided treatment have their symptoms resolve much faster. They get much less medication than if they had a standard timed dose of medicine. Their symptoms resolve much, much faster, and there's no additional adverse outcomes in patients who are treated this way. So the best way to do this, although there are lots of critics about ways to assess alcohol withdrawal severity, the best tool that we have currently is something called the CWA, the Clinical Institute Withdrawal for Alcohol Assessment Tool. And it's a 10-point compendium or list. 5 of the points covered are actual subjective things, and the other are objective things. So there's quite a bit of room for, and that's one of the criticisms of it, there's quite a bit of room for interpretation, but nonetheless, it is the best way to do it, and our hospital currently uses the CWA protocol. So the patient was started on a CWA protocol, and he got administered intravenous doses of diazepam hourly for the first 18 hours. I will say that this patient was in moderate to severe alcohol withdrawal. The CWA score initially was 13, and eventually it crept up above that. There was a 6-hour delay from the first episode till the first episode of diazepam was administered, and that's really a critical point because the way we need to think about alcohol withdrawal is we need to consider it similar to a resuscitation. You wouldn't take somebody who was septic in, you knew the treatment for them, and they were hypotensive. There's a sepsis management protocol, and it involves doing these things in a timely fashion, and alcohol withdrawal is exactly the same. It's easier to manage it if you get on top of it very early. So there was a 6-hour delay until the first dose was administered, and over the course of the next 18 hours, his CWA stubbornly stayed at around 18, which is bordering on severe. By the 15-hour mark, his CWA had increased to a score of 21, despite receiving 20 milligrams of diazepam hourly. And by 18 hours, he'd had a total of 240 milligrams of diazepam and actually was getting worse. His CWA score was up to 21.
Yeah, there's a few things in that case scenario, especially with regards to the management, that are a little disappointing or upsetting. The 6-hour delay, of course, the progression of the condition despite providing benzodiazepines. And then the final thing was by the 18-hour mark. Now, when you say by the 18-hour mark, this patient is still being managed in the emergency department at 18 hours. And that's an unfortunate sort of commentary on our current system where, we would expect these people, once we've diagnosed them and figured out exactly what was going on, we should be able to disposition them and get them into an inpatient bed where the inpatient service can manage them. But unfortunately, that would be the exception. The rule is that these people are in almost for a 24-hour period.
The thing of it is only about 10% of people with alcohol withdrawal ever get admitted to the hospital. The vast majority of people with alcohol withdrawal can safely be treated in the emergency department and discharged home if it's done properly. And there's some fine points about that we can talk about if there's questions. But, the reality is a 6-hour delay. He came in the middle of a busy emerge day, in the middle of COVID, hard to get beds. And I will say our nurses did an incredible job looking after him. I mean, he had a CWA done every hour for 18 hours. That's a lot of work. The missing link was that somebody needs to appreciate the patient is not improving. So this is not just like giving somebody a blood transfusion and just keep doing it ad infinitum. The important thing is if the person is not improving with appropriate treatment, and 20 milligrams of diazepam intravenously is a reasonable place to start for somebody like this, then something else needs to happen, right? And that's really, I think, the key. If this could be criticized for anything, it's the fine point of keeping an eye on the larger picture. We're doing the things that we're supposed to be doing, but the thing that's missing is the appreciation of the fact that this person was not improving. And I think the reason they got signed over, I was the fourth emerge doc to inherit this patient. And I think the reason that happened was because everyone expected that he was going to improve.
Yeah, and I don't want any of my comments to come across as criticizing any individuals or the people that are working in the emergency department. This is a system problem that leads to 18 hours of being in the emergency department and patients maybe getting worse instead of better, despite, providing appropriate treatment. And the other thing you said was, it was a busy day in the emergency department. I don't know what it's like where you work, but I think that's a day that ends in Y where I work. I mean, every day is busy now, unfortunately, and it represents the standard is, oh my goodness, it is overwhelming sometimes, or not sometimes, overwhelming.
Yeah.
But the clinical question, though, that I wanted to get to was, you've given 20 milligrams of diazepam hourly. This patient's had a total of 240 milligrams of diazepam and it's getting worse. So how about phenobarbital in addition to all this diazepam? Would it be helpful in managing the case of severe alcohol withdrawal?
Yeah, so that was our clinical question was, there's a lot of people talking about phenobarb now. There's a lot of people interested in finding ways to manage these kinds of patients because they're not that uncommon. I will say that if this person had gotten more aggressive management with benzodiazepines, it's possible that they would not have needed it. But nonetheless, the purpose of our review was to ask exactly that question. Is there a role for adjunctive phenobarb? So phenobarb in addition to diazepam for managing this case of severe alcohol withdrawal.
And what did you and your group conclude?
We concluded from our review of the literature that there is limited direct high-quality evidence from clinical trials supporting the use of phenobarb as an adjunct to benzodiazepines for managing moderate to severe alcohol withdrawal syndrome in the ED setting. And although the direct prospective evidence comparing these interventions in the ED patient population is limited, the balance between desirable and undesirable effects favors adjunctive phenobarb over benzodiazepine alone. And this is specific to patients with moderately severe to severe alcohol withdrawal who are going to be admitted to the hospital. And this is largely based on indirect evidence illustrating the effects of adjunctive phenobarb, including, but not limited to, a reduction for the need for intubation, decreased overall hospital length of stay, decreased ICU admission, and decreased length of ICU admission.
And so your group came up with a recommendation, and that was that in adult ED patients with moderate to severe alcohol withdrawal who are being admitted to hospital, we suggest using phenobarbital in addition to benzodiazepines as compared to using benzodiazepines alone. And this was a conditional recommendation based on low or very low certainty of evidence. And with the recommendations that you had in this GRACE4 document, you also have some good practice statements. I'm not going to go through those. I will list those in the actual blog.
Great.
How about resolving this case of the patient that received the 250 milligrams of diazepam? I'm interested in what's the dose of phenobarb? What dose do you use?
So it's a challenge because the dose used is widely variable, and we weren't able to come to any real consensus in reviewing the literature. It seems like a total dose of 10 milligrams per kilo of phenobarb is a reasonable place to start. I confess I haven't used phenobarb a ton in the emergency department because usually I'm pretty aggressive with my benzodiazepine management, and we're able to resolve it that way. But in this case, after getting 240 milligrams of diazepam with no improvement, I gave him 5 milligrams per kilo of phenobarb as an infusion. The infusion went in over 20 minutes or 30 minutes, and the patient's symptoms showed significant improvement. They weren't completely resolved. An hour after the first dose was initiated, I gave the patient an additional 5 milligrams per kilo, and that resulted in near complete resolution of all of the symptoms. So a total dose of 10 milligrams per kilo.
All right, that resolves case number 1, and we've got 3 cases to go through. So let me set up case number 2. This is a patient who presents to the emergency department with moderate alcohol withdrawal. She's been consuming 26 ounces of vodka per day, and for the last 4 years. She has no history of being admitted to the hospital for the management of alcohol withdrawal syndrome. And so this is different than the case number 1, where this patient has not had previous admissions.
Similar to the previous patient, we treated this patient with diazepam using, again, a symptom-driven approach, including hourly CWA assessments, and using long-acting benzodiazepines, specifically diazepam, to manage symptoms according to the severity. And this patient's alcohol withdrawal syndrome resolved pretty promptly over the next 8 hours, and she was ready to be discharged home by the end of the shift. So we historically now make referrals to local addiction medicine services, the rapid access addiction medicine clinics, or RAM clinics, which are now spread out across the hospital, although they're not available in every community, for her to be seen within the next couple of days.
And so the clinical question you were trying to answer with this case is, should this patient that we described be offered anti-craving medication upon discharge?
That's right. It's interesting about anti-craving medications. These drugs, the main ones that we've talked about, the 3 that we've talked about in our document are naltrexone, acamprosate, and gabapentin. These drugs have been available for decades. Naltrexone and gabapentin have been approved for use in alcohol use disorder as anti-craving medications. And depending on where you look, in the data that I've looked at from actual patients seen locally, the number of people getting anti-craving medications in emergency departments is less than 1%. And that's important because I think emergency physicians are probably the group of healthcare providers that interact most with these patients. People with alcohol use disorder don't want to go to their family doctor. They don't like to talk about this issue. But we have them at a moment where there's clear evidence that they've suffered some harm. And so I think we're best positioned to be able to offer that treatment. And, there's limited high quality direct evidence for the use of anti-craving medications in the ED for the treatment of alcohol use disorder. But despite this limitation, the balance of desirable and undesirable effects favors prescribing anti-craving medications in the ED for people with alcohol use disorder. Depending on the outcome, the number needed to treat for good outcomes is in the range of 3 to 12. So these drugs are quite effective. And our conclusions were based on indirect evidence demonstrating effectiveness of naltrexone, acamprosate, and gabapentin in reducing heavy drinking days and helping to increase abstinence. In addition, these medications were pretty well tolerated with very mild side effects.
So this generated one main recommendation with a few sub-recommendations. So the main recommendation was that when you have an adult patient presenting to the emergency department with alcohol use disorder, your group suggests a prescription for anti-craving medication for the management of alcohol use disorder for patients who desire alcohol cessation. And this is a conditional recommendation based on very low or low certainty evidence. Again, there are some good practice statements, and I'll list those in the show notes. But tell me, what was the subcategory? What was recommendation 2A for this case?
So our subcategories looked at the specific anti-craving medications I just mentioned individually. So recommendation is 2A is that in adult patients over the age of 18 with alcohol use disorder who are not taking opioids, that's important. Naltrexone is a potent opiate mu receptor antagonist. That's believed to be its mechanism of action. It takes away the joy that some people get from consuming alcohol. We suggest using naltrexone as compared to no prescription for the management of alcohol use disorder to prevent return to heavy drinking and or reduce heavy drinking.
And what about a patient who has a contraindication to naltrexone?
So the main contraindications to naltrexone are the ones one of the ones is I just mentioned is they're taking or planning to take. Somebody's going to have an operation, for example, uses opioids because it will precipitate withdrawal. It's a very potent antagonist. The other is obvious evidence of liver failure because it's hepatically metabolized. So recommendation 2B is that in these same patients with alcohol use disorder with contraindications to naltrexone, we suggest using acamprosate as compared to no prescription for the management of alcohol use disorder to prevent return to heavy drinking and or reduce heavy drinking. We favor naltrexone for a few reasons. One, it's easier to take. It's one 50 milligram tablet a day. Acamprosate is a TID dosing, so it's harder for folks to remember to take pills 3 times a day.
But there was a third medication, gabapentin. What did you come up with for a recommendation around that drug?
So recommendation 2C is that in adult patients, the same patients we're talking about with alcohol use disorder, we suggest gabapentin as compared to no prescription for the management of alcohol use disorder to reduce heavy drinking and or improve alcohol withdrawal. There are some specific things in Canada, acamprosate and naltrexone, or in Ontario anyway, acamprosate and naltrexone are covered by the Ontario Drug Benefit Program. If somebody is not covered by that program and money is an issue, gabapentin is much less expensive and also extremely effective. We also recommend potentially using it in addition to one of the above mentioned medications for people who have previously stopped drinking and have had prolonged subacute alcohol withdrawal, so disturbed sleep. Craving isn't just going to go away magically in a couple of days for people with sustained alcohol consumption over prolonged periods of time, and gabapentin is effective for treating that.
And just to remind everyone, these recommendations are based on low or very low certainty of evidence. Can you resolve this case where the patient had a moderate presentation but was able to resolve within 8 hours?
Yeah, so the fact that the patient's alcohol withdrawal syndrome was well controlled, they were comfortable, they were treated with a long-acting benzodiazepine. I'm going to keep reinforcing that point. Lorazepam has a half-life of 8 hours. Benzodiazepam and its active metabolites have a prolonged half-life over 96 hours, which means they're going to metabolize that drug slowly. If you remember your basic pharmacology, it takes 5 half-lives for something to be completely out of your system. So they're going to metabolize that long-acting diazepam over a long period of time. So if they were comfortable and they were safe to discharge home, and in which there's an exploratory conversation about the effects of alcohol consumption that the level of drinking this patient was indulging in was having on their health, this particular patient was becoming interested in being abstinent. He tried and failed many times, but he'd never been treated with any of these anti-craving medications or had specialized addiction medicine support. The patient was offered and accepted 50 milligrams of naltrexone per day, was given a 10-day prescription, which is fine. You don't have to do blood work in the emergency department to check liver enzymes or liver function. for such a short prescription, and we made a referral to the local addiction medicine clinic for follow-up, which usually happens in a couple of days.
And when you said long-acting benzodiazepines, you're specifically referring to diazepam, correct?
That's right. Diazepam is the one long-acting benzodiazepine that we have access to commonly, and it's by far and away the preferred drug. It's unclear why many people choose to use lorazepam. The thing that you have to know about lorazepam is you're going to have to keep doing a CWA score for a long time because they're going to metabolize that medication very quickly. There are some instances where you might want to use that in frail elderly patients, but that's not safe to send somebody home. Even if you were able to get on top of their alcohol withdrawal syndrome with lorazepam, they're going to go back into withdrawal, in less than 24 hours because that drug is going to be metabolized out of their system.
So diazepam should be selected in most cases over lorazepam, correct?
Exactly right. Yep.
Well, those are the two cases that we had revolving around alcohol use disorder. Now let's switch gears and talk about cannabinoids. So case 3 is a 28-year-old patient with no prior abdominal surgeries, and they present to the emergency department with a 24-hour history of uncontrollable nausea and vomiting. And usually we can hear these people who are just retching and retching and retching. They're not able to get comfortable, and they're in a lot of distress. This looks very unpleasant. They've typically had several ED visits to the hospital with similar presentations. And on each occasion, the patient has been treated with fluids and antiemetics, pain medication, and often they undergo multiple diagnostic investigations, including ultrasounds and CAT scans, and they never find the underlying cause for the patient's symptoms until somebody sort of clicks in and said, hey, maybe this is due to cannabinoids. On one previous occasion for this case scenario, we have that the patient was admitted to hospital for further treatment and observation. So let's talk about that case.
So this is an increasingly common condition, I think, which will be familiar now to most emergency physicians, and a very frustrating one to deal with because, as you said, Ken, patients are extremely uncomfortable and in distress. They have uncontrollable retching and vomiting, can't take anything by mouth. They have abdominal pain. In this case, the patient was again treated with IV fluids and antiemetics, the usual things on Dancitron, Gravol here in Canada, which are not effective, which is typical in bringing this patient's nausea and vomiting under control. On further questioning, this patient says that the one thing that typically brings any relief is very hot showers, which this person has been taking over the course of the day, so many, many hot showers. And that's kind of pathognomonic, as we all know, for cannabis hyperemesis syndrome. But as soon as he gets out, his symptoms get worse. They return. During your physical exam, you become aware of some smell of cannabis on the person. So you put all these things together, you ask about cannabis consumption, and you have a conversation with the patient about this condition, cannabis hyperemesis syndrome, and you make that provisional diagnosis.
Yeah, the tip-off can really be when they come in and they talk about taking prolonged showers or prolonged baths, the repeat visits to the emergency department, the quote-unquote negative workups, and the fact that nothing really seems to work. I would not want this. This looks horrible. These people are very, very uncomfortable. I don't have a sense of smell or taste, really, so I can't smell much in the emergency department. That's one of my superpowers, though. So I get all the INDs, all the abscesses. I'm like, sure, yeah, I can do that. But I don't have a great sense of smell to be able to pick up on these strong smell of cannabis. But the nurses bring it to my attention. And so there's always somebody that can sort of pick up, there's something smelling going on there. But the patient comes in really clean because they've just gotten out of a hot shower.
In speaking with patients who have had cannabis hyperemesis syndrome, they do say it's an absolutely horrible thing to go through, as you could imagine. The other thing that we learned, which is quite interesting, is they are often not very well treated. People often view them as drug seekers, and so they can almost sometimes become secretive about things that have been effective or try not to be entirely truthful with clinicians about their particular condition, that they've had it before, and so on. So I think it's, just like with all patients with addiction, approaching these patients in a non-judgmental way with a little bit of compassion, I think goes a long way in helping develop a good therapeutic relationship and helping them get better quickly.
That's such an important point to make about that. We're there to help. We're not there to judge. And it is a miserable looking experience. And it's unfortunate that, you probably picked this up from the layperson on your committee, that, they may be reluctant to volunteer or be completely transparent because of how they were treated in the past. And that's on us. That's on us as a group of clinicians. We need to do better that way.
Yeah, that message did come across people who have had multiple hospital visits, and I think it's an important one.
So for this clinical question, your group was looking at, does the use of dopamine antagonists like haloperidol or droperidol or capsaicin, as compared to usual care or no treatment, lead to improved outcomes?
That's right. And we concluded from our review, as with the others, there's limited high-quality evidence evaluating the use of either droperidol or haloperidol in the treatment of cannabis hyperemesis syndrome in the emergency department. However, the balance between desirable and undesirable effects supports the recommendation of these agents in comparison to the lack of effectiveness of standard therapies for symptoms related to cannabis hyperemesis. And indirect evidence supports the use of these drugs in managing nausea and vomiting for non-cannabis hyperemesis related presentations with low rates of adverse effects. Capsaicin, is derived from chili peppers. It's a topical ointment. I'm not sure how many emergency departments stock it. We do. And it was something I was very interested in myself, because our person with lived experience said that really acutely applying capsaicin didn't have any effect. And I was skeptical about that. So I got some capsaicin and applied it to myself. And she wasn't kidding. It felt a little bit like body lotion for the first hour. But after that, you do start to feel that burning, and it's kind of like getting a bad sunburn. If you leave it on there for hours, you do get this painful sensation in the skin. So I think one of the things to remember about capsaicin is it's not really going to work acutely. It also received a conditional recommendation for us. Their evidence is supportive of capsaicin, but it was even more limited than the recommendation for haloperidol and droperidol, based mainly on the lack of significant side effects, though, and the low cost and the ability of the patient to apply this medication at home after discharge. We felt that it was probably worth making some recommendations about. So improvements in prompt access to capsaicin in the ED and support in removing the necessity of cardiac monitoring, for example, that is required for haloperidol and droperidol in some places, might ease concerns regarding the feasibility of implementation.
Yeah, my concern as a skeptic would be that this would be a placebo effect. It has a certain smell, perhaps the rubbing on the abdomen and then getting that burning sensation could be all an elaborate placebo effect.
That's why I tried it. It actually works, though. You'll get red skin. It'll hurt a lot the next day. It'll if you put a lot on, your skin might even peel. I think it's important to try it yourself and see.
So what you mean by it works is that it causes redness and irritation, and maybe that distracts you from your nausea and vomiting to some limited degree. But does it actually, quote unquote, work?
So, part of these guidelines is to help inform future research. And so one of the things to think about is, okay, there's limited evidence for this, but it's super easy to apply. It's very inexpensive. Patients can use it on an ongoing basis. They just put a small amount of it on their abdomen. It's worth doing some research studies to determine actually if it has any impact at all. But the idea is that it mirrors the effect of a hot shower on your skin.
Okay, so that's what they're going for, is that sort of warm feeling that you get with a hot shower, prolonged hot shower. All right, what recommendations did you come up with?
So for recommendation 3A, this relates to haloperidol and droperidol, that in adult patients presenting to the emergency department with cannabis hyperemesis syndrome, We suggest using those agents in addition to usual care, serotonin antagonists, and ondansetron, for example, or Gravol, and IV fluids to help with symptom management. And we came up with a conditional recommendation here for very low certainty of evidence.
And for the recommendation about capsaicin.
Yeah, so the recommendation for capsaicin is in patients presenting to the emergency department with cannabis hyperemesis syndrome, we suggest offering the use of topical capsaicin in addition to usual care to help patients with symptom management. And specifically, we recommend asking patients if they've ever had it before. Some of these things require, patients with cannabis hyperemesis may wonder why you're offering them an antipsychotic or chili pepper treatment for their severe abdominal distress. And, I think it's worth explaining to them that these are off-label uses of these medications and that we think they're helpful, and that's why we're doing it. If they don't want it, then that's fine too.
Well, I think the band name, the Red Hot Chili Peppers, is a much better band name than calling it capsaicin.
The hospital has a step challenge going on right now, and my team is called the Red Hot Chili Steppers, which I thought was clever, but it turns out a lot of people have used that same name. But anyway.
All right, so how are you going to resolve the case?
So the patient was offered and accepted treatment with haloperidol administration, 2 milligrams IV, in addition to the other usual treatments for unremitting nausea and vomiting. Their symptoms markedly improved over the following 30 minutes. With additional IV fluid management, the patient was able to tolerate oral food and fluids. The patient was also offered capsaicin, and a small amount of it was applied to their abdomen, which is where it's recommended, a 15 by 15 centimeter patch of skin. And with the proviso that you're not going to feel this for a little while, don't wash it off. And it might help you. There's concern that once the haloperidol wears off, people will have to come back to the hospital, which is obviously not good for patients and not good for us. So we'd like to do, if there's something we can do to help patients after we send them home, that's what we'd like to do.
Well, my clinical experience to date has been haloperidol does seem to work. I've not used capsaicin and offered it up to this point, but I have found that the haloperidol does work in the cases that I've tried it in. And I'm not starting with other agents like ondansetron if I know that they have a diagnosis or we're confident in the diagnosis. I'm starting with haloperidol now and getting some good results.
I have to say I've had the same experience, and if you start talking to emergency physicians, I think many will tell you the same. There's a limited downside to it. It's a small dose. Some people get akathisia. They get up and they get a little restless. You can manage that with medications as well, but it does seem to resolve it much faster than anything else.
Well, I do like to give top 10 lists because it's a doubling of my favorite number of 5. And with you here, I thought maybe we could just go back and forth and give 10 takeaways on this topic from the GRACE4 guidelines. Is that okay if we go through a sort of circle back and do some spaced repetition?
I'd love that.
All right, so I'm going to go first, and that is ED visits related to alcohol-related conditions exceed the combined number of visits related to all other recreationally consumed substances. This is a big deal.
Greatly exceeds. It's remarkable. 270 or 280,000 cases a year in emergency departments in Ontario. Second point is that ED providers, as I think I alluded to before, we are the best situated people within the entire healthcare system to recognize and offer help for people with addiction and alcohol-related problems and cannabis-related problems. We are the people who encounter these patients the most. And usually when we do, I think we have the opportunity, because some harm has come to them one way or the other, that they're here in the emergency department with us. So I think we have the best opportunity to have that golden teachable moment.
Yes, many other healthcare workers do help in this area, but the unique aspect of emergency medicine is we're there 24/7, 365. We're open when some other access points are closed. And so this represents a real opportunity for being able to help these people.
Yep.
The third point is, there really is a lack of education in medical school and residency training on how best to manage alcohol-related conditions in the emergency department. And with the statistics you've given earlier with regards to, the number 3 cause of mortality worldwide, the fact that these ED visits related to alcohol exceed vastly the combined number of visits related to all other recreationally consumed substances, I would have appreciated more education during my training on this area.
Yeah, it's a great point, and I think there's growing interest, amongst medical trainees. My hope is that, lots of different, I work in a teaching hospital system, many of us do. It's a great opportunity to demonstrate for trainees, hey, there's treatment available. And I think the funny thing happens when people know that there is treatment available and they feel confident they know how to use that treatment. I think it does a lot to impact the sort of I don't know what the right word, but certainly the stigma of these conditions, right? People have a little bit more sense that this is a medical problem. There's treatment available here that's effective. We should be treating these patients the same way we try to treat everybody else. Point 4 is that even though anti-craving medications have been around for a long time, they are extremely safe and effective, and they're prescribed to less than 1% of patients with alcohol use disorder, despite their proven effectiveness.
Yeah, and that less than 1% that gives us a huge growth opportunity. There's a real opportunity to have a positive impact and move the needle significantly when you're starting at such a low number.
If you speak to a lot of people, I know lots now of people who are recovered alcohol use disorder patients. It's incredible. They get their life back. These were lovely, interesting, smart people before they developed problems with alcohol use disorder. They get their whole life back. And to think that we have the opportunity to start that journey for them, that pathway, for me at least, it's extremely motivating.
The fifth point is that cannabis hyperemesis is a real thing. Now, I don't know if you've experienced this, but I often receive pushback from the patients that they don't think, well, it can't be the cannabis. Cannabis makes me feel better. Cannabis helps me with my nausea. But it is a real thing. Cannabis hyperemesis is a real thing. And these patients can be challenging to manage. And it's not them, it's the medical condition that they have is challenging to manage when so many things don't usually work and are not effective. Now, while the scientific evidence for dopamine antagonists and capsaicin is poor, the anecdotal evidence of their effectiveness, especially for the dopamine antagonists, is growing. And it's a bit surprising that, something that has this amount of impact on emergency department visits and all the statistics we've been throwing around, that there isn't a lot of evidence. Just because we don't have the evidence doesn't mean these products or treatments don't work. It just means we don't have a lot of good evidence to support their use. And I hope by doing GRACE4 and doing this knowledge translation, we will encourage people out there who are interested in doing research to explore this area further and give us really good, high quality evidence to inform our care.
That's point 6. Thanks for the great segue. There's a strong need for additional evidence in all of these areas. The important thing is, though, the existing evidence, although the evidence is low, it does support the regular use of these treatments for these conditions. So there's no reason to wait for more evidence. The downside is minuscule. And one thing we know for sure, doing nothing is not helpful.
And providing these clinical practice guidelines should encourage clinicians to consider using these treatments. Additionally, giving clinicians advice on how to manage these conditions where there has been not great amount of education on this. Hopefully this will create an environment where the patient collaborates with a caring healthcare worker and reduce the stigma around substance use disorder in general.
That's right. I think encouraging honesty and compassion in the emergency department is the key to trying to help people. Point 8 is, it's very challenging for patients to overcome alcohol use disorder on their own. But with medications and support, there's a great chance that they can achieve these objectives for alcohol consumption and get their life back. They can restore their family relationships. They can find a place to live. They can get back working. All of these things are very possible.
And the only cure really for cannabis hyperemesis syndrome is cessation. I'm often saying in the emergency department the difference between a drug and a poison. And as a pharmacologist who has a PhD, you might like this. The difference between a drug and a poison is dose and duration. And so the real only cure for this hyperemesis syndrome is decrease, cessate, stop using. There are anecdotal reports that significantly reducing consumption can reduce the frequency and severity of cannabis hyperemesis syndrome, but it's unclear if this is 100% effective of reducing the incidence. The only cure, the only way to stop having cannabis hyperemesis syndrome, the only proven 100% effective treatment is don't use cannabis. Now, I'm not saying that you can't use cannabis. I'm just saying that's the only thing that we know is 100% effective, but it's dose and duration. Or I think that there was, what was that thing at the Oracle of Delphi? Everything in moderation.
Everything in moderation. That's right. The last point is, I think the message from all of this should be, we can help. Emergency care providers can help these patients. There are tangible, real things we can do for them that will improve their outcomes and improve their life. And I feel like we should be doing our best to help them the same way we help somebody with diabetes or COPD or coronary artery disease or any other, medical condition.
Well, we've covered alcohol use disorder and cannabis hyperemesis syndrome on the SGEM, and I will list those previous shows in the show notes if people want to go back and take a look at those. But I want to thank you for coming on and highlighting GRACE4, actually for putting together and doing GRACE4 and having that team of authors and some lay people to put together these guidelines. And even though we have limited, very low or low level of evidence, this is the best evidence we have. And this is not a unique situation in emergency medicine or in medicine in general. Often we don't have high quality evidence to inform and guide our care, but it's the best evidence we have. And that doesn't paralyze us into inaction. We can still do something. And I like your 10th point. It has a positive message. Yes, we can help. We can do something. We can make a positive impact. We just have to try.
Yep, I agree completely. I'm just reminded as you were talking about the need for evidence, I don't know if you remember, but when I started practicing emergency medicine, Ken, do you remember how complex the ACLS algorithms and pathways were? I think we had 3 different types of antiarrhythmic medications, only to be used in certain instances. And, as time has evolved, these things were taken for gospel. These are the things we have to do. But for many areas in medicine, we do things with really no good evidence. Here, there is some good evidence that this stuff works.
Yeah, I can date myself, and I want to avoid the feedback. Okay, boomer, but let's see if this triggers any memories for you. Ready? Here, you ready to go?
Yep.
Here we go.
Yep.
Shock, shock, shock. Little shock, big shock, mega shock. Do you remember that little saying for ACLS?
Yep. Beryllium, amiodarone, all the different kinds of antiarrhythmic medications we used to give, lidocaine. None of that is part of the standard treatment anymore.
But if you go back and watch that classic 1980s movie with Kiefer Sutherland about, what was it called? Flatliners. Oh my goodness, you're giving them beryllium? You'll fry their brain. It's amazing how I can remember everything from 40 years ago from a movie, but I'm having a hard time remembering, oh, geez, where did I put my reading glasses? Okay, yes, we're drifting into the okay boomer stuff.
Yep.
All right, the SGEM will be back next episode doing a structured critical appraisal of a recent publication, trying to cut that knowledge translation window down from over 10 years to less than 1 year, using the power of social media, so patients get the best care based on the best evidence. Thank you so much for coming on and doing this show.
Thanks, Ken. It's really been a pleasure. This is a topic that I, unfortunately for your listeners, could probably talk about all day long. But I think it's a wonderful opportunity to try and share the results of this work. It was several years of hard work, systematic reviews, combing over evidence, coming up with suggestions that we could all agree on. And I think it really is a state of the art for treatment of these conditions at the moment.
Well, before you leave, Can you do one final thing and read the SGEM tagline for us?
I can. Remember to be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.
Talk to everyone next time.